All right, looks like we've got a good group. Hello, everyone. Thanks for joining us for From Police to Prevention. We can prevent overdose deaths. I would like to start with a couple of reminders. The session is recorded and will be available on the conference platform 1 hour after the session ends. Please keep yourself muted unless Daniel asks you otherwise. Make sure to join sessions live today because we will be doing prize drawings from attendance within each session. The conference is also offering free continuing education credits. For more information, visit the continuing education page. Please remember to ask any questions. They'll be answered at the end in the chat box on the webpage in the Pathable box, not in Zoom, and we will get those taken care of at the end. Today, I'm excited to introduce Daniel Donovan. He's the Prevention Services Community Support Specialist at DECA for the South Central region of Kansas. Daniel and his wife of 5 years, Dr. Reba Donovan, live in Wichita, Kansas with their dog, Scout, and cat, Oakley. Daniel spent 4 years in law enforcement and 6 years in manufacturing, learning about community safety, leadership, teamwork, and process improvement. Daniel is passionate about supporting coalitions as they strive to improve communities across the state of Kansas. Daniel is a trainer for DECA's Opioid Overdose Recognition, Response, and Emergency Administration of Naloxone Training. Daniel uses his training to advocate for the availability of naloxone to law enforcement agencies and the general public to reduce overdose deaths and give people with substance use disorders a second chance to find treatment and recovery. Daniel believes through education, awareness, and understanding of opioid use disorders and naloxone administration, the wave of opioid overdose deaths can be stopped. Daniel, I'll turn it over to you.
Thank you so much, Patricia. I appreciate it. All right. Well, I appreciate everybody being here. The message I'm trying to get here is I'm trying to challenge several misconceptions and long established beliefs around substance use and the impact that law enforcement has on those. So I want to challenge the way people think on how we view law enforcement and their role around substance use, the long-term impacts of recovery on community wellness, as well as the way law enforcement approaches substance use and recovery. But I want to just re-emphasize as much as possible that law enforcement can make a difference. And then I'm going to wrap up by talking about assessing need for naloxone within communities and within organizations, including law enforcement agencies, and then talk about what I could call prioritized allocation of naloxone to make sure we're making the supplies we have go as far as possible to have the biggest impact in the community. So several of these first slides are going to be quick review, and we're going to breeze right through them. We know that the leading cause of overdose death is opioids specifically. They account for about 69.5% of all overdose deaths. If you were in the general session or the keynote speaking session this morning, they had more data on the 3 waves than even what's provided here. But we know now, talking with different agencies and organizations, that fentanyl is at the root of most drug overdoses now, even as the specific opioid that's involved. It's involved in about 30% or more of all cocaine and methamphetamine overdoses. So due to the nature of drug overdoses, law enforcement has always played some kind of role in responding. And over time, agencies began supplying naloxone, which we know by its brand name Narcan. As the opioid overdose epidemic continues, more and more agencies are reaching out to us, DECA, for training in opioid overdose recognition and emergency administration of naloxone, because they recognize the need in the community and the growing concern over the risk of secondary exposure to fentanyl. There are 2 specific reasons that law enforcement will carry naloxone, and depending on the state and the agency, it won't always be for both reasons. But right now, these are the 2 areas: self-defense against secondary exposure to fentanyl and emergency administration to the public. Now, one of the things to keep in mind as agencies begin training around naloxone, many are making it available for officers to administer during emergency overdose responses to the general public. But when considering a naloxone program with an agency, they have to consider the cost because Narcan is pricey. It can range between $80 and $160 depending on the pharmacy, depending on the state, and things like that. So some agencies can't effectively replace used or expired naloxone, particularly small agencies with small budgets. And this unfortunately can leave officers and deputies feeling unprotected as they can't get a replacement quickly, and then they're unable to provide future emergency administration to the public and to fellow law enforcement officers. So one of the other things we're going to talk about is the risk of secondary exposure and then how we can address it. So unlike most equipment issued to police officers, Narcan will expire within 24 to 30 months on average, depending on how quickly they acquired it after it was produced. Some agencies found it impractical or simply too expensive to maintain naloxone department-wide. I had a chance to meet with officers from alcoholic beverage control out of Arizona, and they're actually prohibited by policy and by restrictions from administering naloxone to the public. And so the naloxone they are only issued that kit, and that is for their protection. And that's one of the things, it's a barrier to public administration that they address in a different way, and that I'm going to try to unravel and propose better solutions than having policy prohibiting public administration. So one of the key characteristics sought in a law enforcement officer is the ability to assess a situation and proceed in a manner which best eliminates risk, both to the officer and to the public. So as fentanyl became a greater threat to communities, officers began assessing the issue and then seeking ways to reduce or eliminate the risk. So this resulted in a lot of individual officers seeking out either training or just naloxone on its own. Many have come to DECA to request an naloxone, and we're able to provide that through our state opioid response grant. Others just bought it over the counter from a participating pharmacist. So those who purchased it over the counter without training are at a disadvantage because they don't have the best information around how to identify and respond to an overdose. And in the process, they're not going to be able to most effectively save a life when they have the opportunity to do so. So when I first developed this presentation, my focus was on getting naloxone into the hands of every officer and deputy in the state of Kansas to prevent secondary exposure to law enforcement and encourage public administration. But the more I learned about the risk of secondary exposure to fentanyl and the logistical aspects of providing naloxone to every officer, I realized I had to adjust the presentation accordingly to ensure that what I'm promoting has the integrity that it needs to reach the law enforcement agencies in question. So this is the question I want to ask. What is the risk of secondary exposure to first responders? There have been a few high-profile instances where fentanyl was reported to be causing an emergency overdose situation. The issue with these instances is they are never medically confirmed. So none of them have ever listed fentanyl exposure as the sole reason for the emergency because no medical testing is required to confirm an opioid overdose. Oftentimes they will test the drugs, but they aren't doing tests to confirm that there isn't some other underlying medical issue with that officer who is affected. So keep in mind the means of ingestion for fentanyl by someone who has an opioid use disorder. This won't result in an instantaneous overdose reaction, and the volume and means of ingestion are far more effective than an accidental exposure, say, to the skin. After a well-publicized incident back in July out of San Diego County, several medical organizations, including the American College of Medical Toxicology, released statements questioning the authenticity of the videos released. The concern was that stories of this nature might complicate first responders' ability or willingness to provide emergency assistance if they thought the risk of secondary exposure was too great. And so this is the quote they provided. Industrial workers who produce fentanyl require 200 minutes of exposure unmasked to have 100 micrograms of the drug in their system. And that still isn't enough to overdose. So what they're saying is fentanyl, just on a quick skin contact, something like that, is unlikely to create that overdose emergency on its own. There may be other things that go into place, and there's some speculation on it, but because the range of conditions and the range of individuals who are experiencing these secondary exposures and having an adverse reaction to them are so different, and there's no studying being done on their medical condition, on their blood work. Now, a lot of these will have confirmation of fentanyl in the drugs, but not necessarily confirmation of a lethal or potentially dangerous dose of fentanyl in the system of the officer who experienced a secondary overdose. And that's where the gray area comes in. So when thinking about the risk, I'm not saying fentanyl isn't dangerous. Far from it. The risk of incidental secondary exposure creating an overdose emergency is not what we've been led to believe. All right, officers should be taking every precaution when responding to possible overdoses or when handling evidence that may contain fentanyl. So wear your personal protective equipment like gloves, a mask if you think that there's a risk of airborne particles, err on the side of caution whenever handling, packaging, testing unknown substances, and have naloxone available whenever possible. That's why it's so important to talk about this in this context. Create response plans that allow for the alleviation of this risk without creating a panic. As long as risk is present, agencies should be trying to address it for the well-being of their personnel. The reason I'm challenging perception of risk from secondary exposure to fentanyl is not to shame anybody, but it's just to address another issue that it creates. And so these are the 4 things to keep in mind. It's less common than we believed. Officers need access to naloxone, and agencies should have policy and procedures around it and focus on PPE whenever possible. When I was in law enforcement, the risk of fentanyl became so great that we stopped testing things locally, and we started sending them to the KBI because we could package it and double bag it, whatever the case was, and send it away, and they could test it in a controlled environment with better safety precautions. But here is where the issue is, because a lot of different elements and forces have created barriers to accessing naloxone. And that's both at the citizen level and within law enforcement agencies. Not every agency issues naloxone, but some that do issue it for the sole purpose of officer safety. Now, officers are missing a huge opportunity to save lives by inadvertently restricting their personnel from emergency administration of naloxone to the public. So this is a barrier to public safety, and we can address and remove that. And that's what I'm going to try to do in this presentation. Many officers are only provided naloxone for personal protection, but they aren't forbidden to use it to save someone. But it is why it was issued. So naloxone is used every day in the United States to reverse opioid overdoses, and having it for personal protection isn't wrong. But is that the only reason we have it? So if you're a law enforcement officer, or if you're someone who works around substance use affected individuals, why do you carry naloxone? Is it just for self-defense against an accidental exposure or not? Now, next slide I'm going to put up is going to have what you might consider an ethical conundrum. And this is the one I want people to really focus in on. Now, this is the problem with carrying it only for personal protection. Now, as you look through the list of categories from this question, it's going to seem mildly offensive. So it's oddly specific, and like I said, some people are going to be offended by the language here, and I'm going to address that, I promise. So answer the question this way. On this list from 1 to 16, where do you as law enforcement officers or citizens begin to value others more than yourself? If you could only save one person, where on this list are you most likely to sacrifice yourself? Now, if you've selected number 16 and it's just you, then there's not a lot we can do about that. But this is not in reference, now keep in mind, this isn't in reference to a group incident where only one person is going to survive. This is a dilemma of you versus any one person on that list. So Where are you willing to sacrifice your life to save the other person? You might have multiple answers to this question, but put it in this perspective. If I put this in a poll and I gave you 10 seconds to answer it with 100% honesty, what would you do? How would you choose what to do? So with only 10 seconds to decide, who would you save? And then most importantly, why? What metric did you use to determine your choices? What system or process of elimination did you use in the limited time you would have had to determine whether you would sacrifice yourself to save someone else? And some other questions to think about. Did the language of the questions and the answers make it harder to decide? How did it influence your opinions? And again, why? The wording on that slide wasn't meant to offend anyone. The language is full of negative, biased terminology that we're working to eliminate in prevention. The language, it was designed, however, to highlight that in a scenario with minimal time to decide, our biases will heavily influence our conclusions. So humans are equipped with a very strong survival instinct, and part of survival was valuing your own safety above that of others. Can we see where the problem is with that? As a police officer, you are selflessly giving of yourself to protect and serve the community around you. But this survival instinct still exists. The problem here is that if forced to choose, we are going to assess other people in the scenario and assign life or value to their life and then compare it to our own. So that opens the door to all sorts of complications, internalized bias, high survival instincts, unmanaged anxiety or fear. So many things come into play. So we can rationalize why we would save a neighbor we know or their children. And it definitely gets easier when it's your own family and your own children. But officers didn't sign up to protect a limited number of self-selected citizens in the community. They signed up to protect and serve all of them. So the truth is, this question serves no real purpose. It is an impossible question to answer while keeping in mind the safety of all 16 categories. But this is a question many law enforcement officers are answering when they shouldn't even be facing the question. And I'm going to get into the context of why they're having to answer that. So I'm going to change the context again completely. This is going to be a total 180, but I promise it's going to tie together. In law enforcement, there's a system known as the safety priority list. And for those of you without law enforcement background or training, let me explain. In any law enforcement response, say like a hostage situation, the priorities fall into this order. And this is who you're protecting. So the first one is uninvolved third parties. So these are people not currently restrained or controlled by the perpetrator. These people can and should be removed from the vicinity to keep them out of harm's way. Next, the priority is hostages. We want to protect them. So that's when you'll see them working to negotiate and communicate with the perpetrator for the safe release of the hostages. The next priority is then law enforcement. So we keep our officers out of danger whenever possible for as long as possible. The last priority on this safety list is the perpetrator. And they are last on the priority list because they are the ones creating this extreme situation in which all parties are now involved and potentially in danger. And law enforcement has one specific job during any response, interaction, altercation, or engagement with the public. Do not, either by action or inaction, change the order of this list. If officers always keep this priority in mind, it helps them make smarter decisions tactically, and it ensures the prioritization of public safety when finding a safe resolution to an incident. So then here's how it ties together. What if you took any one of those categories and you place them into the hostage situation as a hostage or as an uninvolved third party? It doesn't matter who they are anymore. So put option number one as a hostage in this scenario, and it doesn't matter. Doesn't matter what they've done, how many times you've arrested them. Your goal is to save them. And that is the perspective I want you to take in, or to keep in mind. So if we change our perspective towards who we could save, we can directly address the key element of this presentation. And we start by the way we look at people. So these 9 categories here, they still include all 16 or all 15 of the other options besides yourself from that ethical conundrum, as I call it. It all still includes them, but the wording is different and it changes the way you would think of somebody. So biased language is very easy. It's a very lazy way to just refer to somebody because it's very conversational, but it's not helpful in any way. So the main aspect and the key element of this presentation that I want to address is that recognition should not determine the value of life. So our ability to recognize people shouldn't affect the value they have, no matter the age, child or elderly. That person's life is valuable. We understand the course of human history of human life, really, that inevitably ends in death. So this knowledge alone can help us cope with the loss of an elder friend or a family member. Their value didn't change, just our perspective on the person's situation. So if we can apply the same lens to substance misuse, substance abuse, we understand the cause and effect aspect of the choices that individual has made, but it doesn't change their value. And we shouldn't be facing situations in which we assess someone's value when we have the opportunity to save a life. So this barrier to saving lives is self-imposed, or it's policy imposed. So if it's by policy, then we have to assess why we have policy written this way. If officers are limited in helping people because they cannot get a replacement, then as an agency, you're putting them into the unfair, unethical situation where in the moment, they might determine the value of someone's life against their own. And that's why resolving the misunderstood risk of secondary exposure is so important, because this is the comparison I want to draw. If you're addressing a risk, look at naloxone this way. After a critical incident in which an officer discharged their firearm, before they return to duty, they reload their sidearm. So why, if you would have naloxone available, would we ask officers to go back on duty when they can be vulnerable and susceptible without naloxone? So why should they choose between their safety later or saving a life right now? I challenged the risk of secondary exposure to help officers understand they don't need to feel unarmed without naloxone. Restricting officers through access or policy puts them into that ethical dilemma. It makes them feel unarmed, and it's unnecessary. So restricted access to another kit of naloxone is a barrier to saving a life. The list of people where you had to choose from in the question illustrates how some people might think and where they might place value in a me versus them scenario. You don't have to choose then, and you don't have to choose with naloxone now. So I'll put the same options up again without the poll. You only have one kit of naloxone and you're responding to an opioid overdose. So who on this list are you saving? Would you hold out in case you get an accidental exposure, or are you saving a life if you're giving it because you're given a tool to do so? So if you respond and use your department issued naloxone, how fast can it be replaced? If the next responding officer has another dose to save you in a secondary exposure emergency, or maybe EMS has it and they're en route, does it make it easier to save a life of anyone on that list? If your department's policy says any officer who uses their personally issued naloxone kit to save a life shall be immediately taken out of service until they are reissued another kit of naloxone, does that make it easier to save a life? I think it takes the subjective decisions out of the equation. It allows us to see people impartially and see addiction as a substance use disorder, instead of just calling somebody an addict. To make our response impartial and free of bias, we can start right there and how we identify people in these categories. It takes time. And I've been in prevention work for over a year now, and I'm still working to change the terminology that I use around substance use disorders. And again, these all encompass the categories from the other slide. Again, this way we can see people, see individuals with substance use disorders as individuals with families and with futures and the ability to change. They just need to be given a chance. We can change the perspective on the way we identify people. And we do that by reframing them according to need rather than perception. The first aspect to address is the difficult unconscious bias aspect of the way humans are wired. If we expect officers to remain impartial, we must adjust this area of police work with naloxone, which can leave responses up to subjective thinking. So that's why policy should promote the ability to administer to the public to some extent. We must reframe the way officers look at people if we want to help the citizens in our communities. So perception is incredibly subjective, which is what makes it susceptible for different types of bias to creep in and cloud our judgment. So let us take the other categories from the initial poll and then reframe them in a way which provides for a more impartial, compassionate, and community-focused or community support-focused response. So first is those who need treatment and or intervention. So people with substance use disorders who spend an extended amount of time in jail or prison will use it as a meaningful first step towards long-term recovery only about 11% of the time. So if you listen to Damon West's story this morning, he is not in the majority. His story is so inspirational because he is not like so many other people. He was able to turn that, but he had those positive influences even when he was in jail and transitioning to the prison. He had those people there at the right time that helped redirect his path. But it's only effective about 11% of the time. So jail isn't effective in helping people find recovery. And one of the things that frustrates a lot of individuals is we want to put treatment opportunities into the jails and prisons. And those programs can be helpful, but what happens is the other side of that coin is as soon as those resources are available in the jails and the prisons, more judges will send people to prison and jail under the guise of now you're going to go get help. And so it will send people to jail who other routes and other options would be a better way for them to go to find recovery. And so it's a two-edged sword. It cuts both ways, and that's why addressing this opioid overdose crisis is such a difficult task, and it's not a black and white issue. It's very nuanced. So suicidal subjects and accidental overdose victims need intervention to get into treatment. If we view this as an opportunity to provide educational material or treatment options, we can have an impact in preventing future overdose. So that may require officers to speak with family and friends on scene at the time of an overdose response. And I also encourage them to have material available to provide to them so they can learn more about treatment options in their area. Even a dealer or a fellow user might be shaken at the sight of somebody they know coming that close to dying. Use that as a chance to make a meaningful impact with somebody who may otherwise avoid law enforcement at every chance. So people suffering from a substance use disorder need treatment, and they often need resources to make a significant change in their lifestyle. So people who have been dependent on substances for an extended period of time are frequently responsible for nuisance crimes such as petty theft, panhandling, but those can even get into bigger crimes such as burglary or robbery as their desperation increases. Their desperation, that addiction that's got a grip on them and it's directing their priorities in life, it only gets worse. And so again, hearing Damon's story where he became a well-organized burglary ring is an example of like what they were willing to do. They were willing to, in 10 minutes, throw a 60+ year sentence at him for being involved in all of these burglaries. But that's where people get to when that substance use disorder gets so extreme. So if you can get treatment to people earlier in the life of their substance use disorder, it can prevent reaching this desperation stage. This in turn lowers your overall crime rate and improves the quality of life in our community as a whole. So compassion for these people early in the process has a long-term positive effect. Turning a blind eye early leads to indifference and annoyance later. So when you see somebody you know is suffering from a substance use disorder and you roll your eyes at dealing with them again, this doesn't work, and it does create more work for your agency down the line. So I'm not saying this because I did it wrong. I came from trying to find the best way to word this. When I was in law enforcement, if there was an individual who I knew was either under the influence right then, and it wasn't in a situation where I could take enforcement action on them, if they wanted to engage me in conversation, I would do what I could to work my way out of that conversation because they can be very awkward. But I didn't know who my resources were. I didn't know where treatment options were available, and I didn't have anywhere to refer them. And so even if they're not going to come up to me regularly, I have limited opportunities to reach them. And so I failed as an officer to provide resources when I had the chance to do so. And that's what I'm encouraging people to do. Learn from my mistakes and be an advocate and a resource for people who need recovery in your community. So most people don't accidentally find themselves addicted to opioid painkillers or heroin. There's so much more to it than that. Past trauma can play a role, and your environment and even community attachment have an impact. There's so many factors we have to address when we're dealing with someone's substance use disorder. We don't educate anyone who isn't law enforcement, a medical professional, a therapist, a counselor, or who is in public health about the factors that can lead to somebody being susceptible to addiction. So we're trying to protect an uninformed public from a community issue they don't understand. That's why there's so much stigma and so much misunderstanding around substance use, is because they have been told one side of things. They've had 100 years or whatever of one-sided opinion on what addiction looks like and what treatment should look like and why we should be helping people to begin with. And because we've done such a terrible job as a society of educating people and saying, hey, let's turn this around, let's talk about options and how we can address this, because we know that throwing people in jail or in prison simply for drug crimes or for having a substance use disorder isn't working to curb this. We're seeing a constant inflation of numbers in overdoses and things like that. So we need to change the way we're doing things. So we can't address bias and stigma around substance use when we haven't even educated the public on how it can begin. We have to take the time to learn more and then pass that information along to somebody who needs it. Because these are all real headlines. Some of these may pull at your heartstrings a little more than others, and not all of these are from the United States. And not all of these are even the direct result of an opioid overdose. But that just goes to show how widespread the drug overdose epidemic has begun or has become. So you may notice something. These headlines compromise most of the list from the poll question that I posted earlier. And so I want to address one other specific thing. So there isn't a person in this session, I believe, whose heart wouldn't break to see a baby dying from an accidental exposure to fentanyl. I doubt there's a person listening who wouldn't gladly give up their naloxone to save a baby. So you would do whatever was possible to protect a child, because these are real headlines too. Again, not all of them are opioid specific, but they're all relatable. Children are at a significantly higher risk of physical, mental, emotional, or sexual abuse when they are endangered by drugs in the home. These are the ones who need to be protected from the environment they are exposed to every day. So we can help someone close to us. It might just be about taking the time to discuss the risks involved with opioids or making sure people have access to naloxone. And we can educate and protect people around us every day, and we should. But what about children at risk of harm because they live with people who are using or distributing drugs? What can we do to help them? So if you're looking for the answer to that question, you can start right here. It's an area I'm very passionate about, and I'm proud to be helping co-chair the Sedgwick County, Kansas Alliance for Drug Endangered Children right now, partnering with the Kansas Alliance as well as the National Alliance for Drug Endangered Children. Use a multidisciplinary strategy to change the trajectory of a drug endangered child's life through recognition of a common vision, ongoing collaboration between disciplines, and ongoing change in practices and policies, all of which will increase the likelihood of better outcomes for drug endangered children. They train practitioners to form community-based partnerships across multiple disciplines and to effectively collaborate with their mutual interests, resources, and responsibilities. They just launched a mobile phone application called Check Deck. And that's Check, CHECK, DEC, which helps connect people to local services and treatment providers to help support children and families who are affected by substance use. So go to that website on the screen and see how you can get involved. There are currently 38 active states across the country. In Kansas, there's about 10 active county alliances for drug endangered children. If you are interested in helping start one in your county, contact me, please. My email is on the slide. I'd be happy to point you towards resources and solutions which you can use to help protect children from abuse, neglect, and trauma as a result of being in a drug endangered home. Because we know that abuse, neglect, and trauma are one of the many factors, or are some of the many factors that lead people towards substance use. And that's how we can change this from a generational problem to an addressed problem. We can't address a generational problem through the methods that have been traditionally used. So the fact remains is that everyone on that list needs to be saved. If they encounter an opioid overdose, they need to be saved. Life is precious, and we should look for every opportunity to protect it from harm and save it from an untimely end. So in an opioid overdose situation, officers can be the first line of defense against overdose deaths. To do that safely and effectively, we must remove barriers to access and ensure officers across the country can access naloxone. So reframing how we see people starts with how we categorize them. What do they need? That is way more important than any assigned title like addict. They will not trust anyone who can help them unless that person first makes themselves a trustworthy resource. And by changing the way we speak about these people, that is how we can break that barrier between us and allow them to come forward and ask for help when they need it. So I'm going to get into an aspect that is a little bit outside of law enforcement, but it's illustrating the barriers that people are currently experiencing getting access to naloxone. First aspect we have to address starts with medical professionals. So these are 7 of the top 15 medical specialties and their co-prescription of naloxone, according to the CDC. Now, this is co-prescription of high dose opioids. It's less than 2% nationally across all medical professions and specialties. By co-prescribing naloxone, doctors can emphasize the importance of safe prescription pain medication management and educate patients on overdose risks and identifying overdoses and responding to save a life. So doctors can help screen for high-risk individuals, such as family members with past substance use disorders and children in the home who would be susceptible to an overdose if they accidentally became exposed to a misplaced pill or a pain patch. This can minimize risk to everyone in the home and show the patient how they can protect everyone at home by having naloxone on hand. Because right now, this is the map of the density map of how often they're co-prescribing naloxone. As you can see, there are some states that do it better, but that range of what they consider to be better co-prescription rates is pretty wide. So even it might start under 2% and be considered a decent co-prescription rate. So there's a financial barrier. Co-prescribing it, again, co-prescribing naloxone with every opioid allows insurance companies to get involved in covering the cost. Most insurance plans will reduce the cost of naloxone and make it more affordable. If on a limited budget, naloxone will not be considered a viable option when faced with what might be seen as a hypothetical overdose situation. So your agency's budget has to be considered when you're starting this program. Orchestrate a proposal when pitching a new budget, which involves naloxone. Assess your community's need for naloxone and propose a budget for the appropriate amount. So what is the appropriate amount of naloxone for each agency? I'm going to give you that tool, and I'm going to attach an assessment tool and or a needs assessment and a readiness. I apologize. A community readiness assessment or tool in the documents on the Pathable site after we get done here. So there are some restrictions on sale and distribution. In Kansas, pharmacists must register with the state to dispense naloxone without a prescription. So this means even if you request it, some pharmacies or pharmacists can't sell naloxone over the counter. They have to sign a protocol and send it to the state first. In Kansas, law enforcement agencies need a medical director overseeing their program to have a formalized naloxone program and policy. And then where demand is low, some pharmacies don't stock it. It has a limited shelf life, and some pharmacies don't see it as a worthwhile investment. Make sure you familiarize yourself with restrictions and requirements when developing your organization's naloxone program. Naloxone serves no other purpose but to reverse opioid overdose effects. It can't be abused. It isn't habit forming. So it really doesn't need to be restricted. So the public should have access to it to protect themselves and those they love. Public education. So I worked with 2 agencies during my career. One didn't provide naloxone. The other did, but never told me what to look for or even how to administer it. So I encountered an overdose where my lack of training prevented me from using it to save an overdose victim. That individual didn't make it. And I will always wonder what I could have done differently had I known how to administer naloxone. No one told me it was a simple nasal spray, which could easily be administered even if the person was not breathing. Because on that scene, the spouse of the deceased had naloxone. They had never been taught how to administer it. And if they had, they could have tried. They were just as lost and uninformed as me. And ultimately, they left a 12-year-old and a 9-year-old without one of their parents because nobody on that scene before EMS showed up knew how to administer naloxone. Now, nothing's guaranteed. That individual may have been unconscious or potentially dead for as much as an hour or more before I arrived. But I will always think about that because it will bother me that I could not do something that I would have otherwise tried based on a lack of education. So I talked about low co-prescription rate earlier. That reflects not only on the medical community, but on the public. So ask your doctor to co-prescribe it to you or a loved one and show you how to use it. Or go to DECA.org and request training. We'd be happy to train you to help prevent overdose deaths in your community. If you don't know where to find resources in your community, you are doing your citizens a disservice. So find the resources, take every opportunity to provide information to the public, and then also please produce material which can be easily distributed at a scene. Agencies already do this for domestic violence. So this is an area to expand in which we can have material available for overdoses. So next, find the policy at your agency around naloxone and opioid overdose responses. If there's not one, you need to make one. Focus on giving officers the ability to save a life and protect their own. If you can't guarantee the speedy replacement of naloxone, you will inadvertently restrict the officer's ability to save lives. So don't let policy be an obstacle to saving lives. Identify the pharmacist in your area and then find out what it takes to build and maintain a supply of naloxone. Monitor your supply and make sure officers can immediately access a replacement. And make it a part of your annual training. Our naloxone training takes about an hour and it can be used for continuing education credits. So make sure your officers always have access to another kit and train them to know the necessary steps to attain another kit and administer and identify opioid overdoses. If not every officer needs naloxone, then make sure you have the necessary supply. And this is how we're going to do that. So here are just 8 questions I'm going to give you on how to assess your agency's or your organization's need for naloxone. Are there a high volume? What is the number consistency of overdose calls or emergency responses? High volume obviously equals high substance use or often drugs tainted with fentanyl. Use tools like odmap.org to track overdose responses and overdose deaths. Currently, there's only about 15% of Kansas counties using odmap.org to track overdoses, and we can do better. Without this data to rely on, we're relying on anecdotal information, which can be very misleading. 2, what's your EMS response time? The longer the EMS response time, the greater the need for law enforcement to have naloxone. EMS can administer injectable naloxone, which is significantly more affordable than nasal spray naloxone. So you need to address that. I saw in an earlier session, somebody mentioned that Wichita doesn't have their police issued naloxone, and they are there typically way ahead of EMS because of staffing shortages with EMS. And that's an area where they can be filling that gap and they can actually be saving a life instead of just being the first one on scene. Then ask, is there high opioid volume involved in the overdoses, obviously. Is there fentanyl laced into the supply of meth or cocaine? And then the volume of seizures may reflect the amount in circulation, or it may help identify major drug supply routes. And so keep that in mind as well. Last, does the public see the need and are officers in danger? So have you had secondary fentanyl exposures or even someone had an overdose reaction that you believed was fentanyl? Those situations, people get very concerned and then they come to us and they need naloxone. Also keep in mind, if you're a border jurisdiction or near a major highway, you could be on a major supply route. And so that can increase your need for naloxone just based on the volume that could be present at any one time. Next, use pharmaceutical data and find out what is the rate of opioid prescription. Is there a high need for Narcan to be co-prescribed by doctors? This is again where partnering with a local pharmacist would be beneficial to assess these statistics. And if personnel are trained, they will provide the best response and emergency aid to the public. Again, keep in mind, this assessment is not exhaustive. There are most likely additional questions you need to be asking to determine your ability to respond. But these 8 questions will start the conversations. So with that, I've identified 5 levels of what I consider agency or community readiness. Level 0, this is where there's no training, there's no naloxone available, the officers are unprotected, the community is not getting a response from your agency or from your organization. So there's no public administration and you're completely unprepared. When an opioid epidemic reaches your jurisdiction, it will not just casually pass through. It will get there and it will be very evident that there's a problem when it does arrive. So level 1, this is where I've had the opportunity to provide opioid overdose response and naloxone administration training nearly 50 times already this year. So more than a quarter of those were law enforcement agencies. Many agencies see naloxone as a priority, but not all of them. Those agencies without a policy or plan for naloxone availability leave their officers seeking out third-party training to get access to naloxone. Those officers who do seek out training are focused on alleviating risk to themselves and not public administration. So those agencies without support for naloxone access will have limited their officers' ability to respond to an overdose. And that's part of that ethical dilemma I discussed earlier. They will do so through ambiguity by a lack of policy around overdose response with or without naloxone. Again, if they assess their need, they may have everything they need with EMS administering naloxone. But without training, those officers are still operating at an informational deficit and can't provide the best responses when they are inevitably dispatched to an overdose scene. Level 2, so the agency prioritizes training and provides naloxone to officers, but they restrict it to officer safety only, prohibiting or discouraging public administration. So this is more common than we want to think. People will think this is unfair for sure, but again, the perception of risk of secondary exposure is quite extreme, and Narcan is expensive. So ideally, those agencies work closely with EMS who have a similar response time, but that isn't a guarantee. So when supply is limited, priorities will be established, and this leaves officers in that ethical dilemma that I discussed earlier. Level 3, my goal is to get every agency in the state of Kansas to level 3 or level 4 if possible. There's going to be some overlaps between 2 and 3 and 3 and 4. But the key difference is the ability for officers to publicly administer Narcan during a response to an overdose. So this is where that community agency assessment tool comes in. At this level, the community needs have been assessed and a need for naloxone in the hand of specific officers has been deemed necessary. This is what I call prioritized allocation of resources. This would apply if you were going to compare an agency with fast EMS response times to an agency with more limited resources or longer EMS response time. This might also apply if you have a part of a community which is difficult to access, such as a bar district, which may close the streets down during large events. With a limited supply of naloxone, an agency or organization can bridge the gap between where EMS may not be able to fill in or respond as quickly. One of the keys to level 3 and 4 is the connection to local resources. So in Kansas, any bystander, first responder agency, or school nurse can purchase naloxone without a prescription. To do so, the pharmacist must have signed a statewide protocol allowing them to dispense naloxone without a prescription. Agencies and community organizations should prioritize partnering with a local pharmacist to ensure they can replace naloxone when it expires or when it's been used to reverse an overdose. Grants like the one we have at DECA, I hope we are constantly renewed for this grant and we can do the training and provide the Narcan going forward, but it's not a guarantee. We all know how finicky that grants and programs can be. They're not always guaranteed. And so that's why these local partnerships are so important to maintain supply and access to naloxone. The key to these last few levels is that agency promotes the training, assesses the need for naloxone, and then writes policy allowing public administration. Some agencies need to issue naloxone to every officer, but not every agency. Some need to prepare a prioritized allocation of naloxone, and keep in mind any organization can assess their response over time. If an agency finds they don't need an extensive supply of naloxone, then they can just donate it to their extra to a local harm reduction organization, or find an agency who still needs naloxone, encourage them to get trained, and then give it to them. If at any time you find you have naloxone gathering dust on shelves and expiring, then you know you have more than you need. So find somewhere that naloxone can do the most good. So here are the things that you can do with naloxone around this. You can train everyone. It doesn't matter if you carry naloxone or not. This epidemic is taking lives across the country. So we cannot afford to be unprepared to respond. Get your agency trained and encourage any community organization who works with or around those who are at risk of overdose to get trained as well. Medical professionals, do your part to increase access to naloxone. Co-prescribe it with every opioid overdose you write, or opioid prescription you write. So even if they don't fill it, you've done everything you can to eliminate that barrier. Pharmacists, talk to your customers about naloxone and then offer it with every opioid prescription. And then openly talk to each other about addiction risk with opioid prescriptions. Keep in mind, an opioid addiction or dependency can start within about 7 days. So that's something you need to keep in mind. So work to eliminate stigmatizing language, words like addict or junkie, anything that labels people and makes them feel isolated from the world. Loss of connection with a family or community support system is devastating to people struggling with substance use disorders. So always know what you can do to direct them to resources and for recovery and support. And then if you can, get trained and carry naloxone, have it available, provide it to the people you can, and do so in a way that will allow you to save lives. It's very, very important to do so. Don't wait. Don't hesitate if you have that opportunity, because I can promise you from experience, every second you're giving somebody CPR, you are also praying that person starts breathing again. So if you're responding to an opioid overdose, give yourself the chance to use every tool available to save that life. In law enforcement, you have unique chances to save lives in the community. So make sure you're doing everything possible to save lives and serve your community to the best of your abilities. Opportunities for training. If your agency needs training, DECA can provide this specific training. Contact one of our prevention specialists and ask what it takes to schedule an opioid overdose and naloxone administration training for you, your organization, or your agency. This is the fastest and easiest way to improve your understanding and help save lives in your community. Here's a list of my resources that I've used and some more. And I want to say thank you so much for your time. I'm going to stop sharing my screen and does anybody have any questions? I have not had a chance to monitor the Pathable platform. Does anybody have any questions around naloxone or how law enforcement can engage or have an impact in opioid overdose response?
I've been watching the chat, Daniel, and I haven't seen any questions come in, but people do have the opportunity now.
Awesome. Well, thank you so much for being here today. My information was on that screen. If you need my email, please drop your name in the chat. If you want to get set up with Naloxone training, feel free to reach out to myself or Krista Machado. We can get you set up. If you're in the South Central region of Kansas, I'm more than happy to work with you to provide that training. And statewide, we can get you in contact with community support specialists who can best serve you and your organization.
That's good. Thanks for being here, everyone.
Awesome. Thank you all. Have a great day. Enjoy the conference. It's been amazing so far.
Many people are sharing that they really appreciate all your information.
Thank you, everyone. I really appreciate you being here. And Patricia, did you get a head count for how many people were in the session today?
I believe I saw 42 at one point.
Awesome. Awesome. Well, thank you so much. I got to dip out and got a lunch meeting that I have to fit in as well.
All right. Thank you, Daniel. See you.
Thanks a bunch.